Oscar was the first company to adopt the concept of narrow networks by market is a far better economic model than full on networks that employers buy, because the economics are fundamentally different. And when I'm an individual buying, I don't have to take what my employer has. I get to look for my network in every market. With 75% of all the providers in a network, the narrow network model is the best economic model for the individual marketplace.
Welcome to Analyzing Healthcare podcast, brought to you by Scale Community. Scale Community is a global healthcare-focused member network where healthcare leaders come to connect, learn, share ideas, and shape what's next in our evolving healthcare landscape. To take advantage of all that Scale Community has to offer, from expansive content to virtual and in-person events, to interactive peer networking opportunities, and more, check out Scale Community at www.scale-community.com. Membership options range from free to paid, so if you enjoyed today's discussion, please take a moment to sign up for your preferred membership level.
All right. Welcome to the latest edition of Scale Community Analyzing Healthcare podcast. I am honored to welcome and introduce Mark Bertolini, the current CEO of Oscar Health, the well-publicized Oscar Health that we've all grown up with, the former CEO of Aetna and EVP at Cigna. So, Mark, welcome.
Thank you, Roy. Great to be here.
So, just to frame Oscar, and I'll do a very poor job. So this is my attempt for you to correct and improve upon. Quick research, 2.1 million members, plus $10 billion of run rate revenue and trailing 12-month revenue, 2,500 give or take employees. So very productive in terms of revenues per employees. 18 states last year, and last year was a break-even year, or plus profitable year for the business, which was a milestone achievement, and optimism going into 2026 that the company can overcome some of these headwinds with ACA and go back to some of the trajectory that it's been on for some time. Is that a fair framing of Oscar?
We're about $12 billion. So that's our guidance to the street is around $12 billion in revenue. So
I knew I would get it wrong somewhere. So thank you for correcting me.
We're a moving target. So
yeah, fair. So let's take a step back. How does Mark, a former auto engineer working in Detroit, end up running one of the country's largest payers and then leading one of the country's most, if not the country's most innovative payer? How does that transition happen?
My whole life, I have been endlessly curious about things. So how does this thing made? How do we make this happen? And so throughout my life, I was always asking questions about what if or why. And as a result, the heuristic that exists in my head about how the world works got larger and larger and larger. And I saw connections. I have a spatial OCD problem. If things aren't in the right place, it bothers me, like photographs or pictures hanging on the wall. And I also have a photographic memory. So the whole thing of trying to figure out how the world works and how I could make it work better was always something that attracted me. And so these jobs, working on the assembly line at Ford, changing the work rules and putting things together, understanding how they're built. I did a wood model maker apprenticeship with my father before I went to the auto factory. He was a model maker, as a pattern maker in the automobile industry. And we worked with wood and how do we build shape and how do we measure shrinkage when you cast these things in metal. So all of that stuff was very just curious to me. And as my career developed, I learned that if I spent more time with people just asking questions, I learned far more than always having the answers.
So the engineering mindset, almost the Denning approach to constant quality improvement. I want to ask you if you brought that optimization of everything mindset into the payer world, and what did that do? What did that do to the payer world, and what did it do with you and your journey, starting with Cigna and then Aetna and then Oscar?
Well, actually, I started a company with some friends out of graduate school called Select Care in Detroit. It was the first physician, hospital, and management-owned for-profit, non-publicly traded company. We grew it to, $1 billion in revenue equivalents over a period of 10 years. And in that company, we tried all sorts of new things because we were going to disrupt the industry by coming to the market. And I remember people saying to me, why are you going to do that of all places in Detroit? Well, that's where I grew up. But why in that industry the big indemnity carriers will crush you. And a mere 10 years later, they were all gone from the scene, and managed care companies were the highlight. And what I found was that the system was incredibly inefficient. And I learned later with my son's illness and my own accident that it was incredibly focused on break fix and not really interested in the human condition. And so as I grew through the industry, I used to add on new things to my thinking, try new things with my company. And I was cleaning out my house in Hartford when I retired from Aetna, and I found this box of acetates. And you probably don't know what acetates are, Roy, but they're these clear plastic films with cardboard rims around them that you would put on an overhead projector as you gave your speech. And it was before PowerPoint. It was before computers. You just stood up there and you threw these things up there, and I would throw a Gary Larson a cartoon or two in there to prove a point. Like somebody sitting at one end of a board and the other sitting at the other. One's playing checker, one playing chess, to describe how just difficult the industry was. And so I'm cleaning it out. I find this box of acetates. I start flipping through them. They were from 1991. This is 2018. And I'm looking at them. I go, oh my God, Human Genome Project. Wow, virtual healthcare. Wow, social determinants of health. And I'm looking at all of this and going, we have come so little in so long. It's amazing. I thought these things were on the edge when I was doing my speeches, and people used to look at me like I had three heads. And here we are still struggling with these very same issues,
Well,
even though we've
we
learned.
do have some virtual health. And we do have some preventative care, but we certainly haven't completed the mission, have we?
No, we haven't.
No, we
We
haven't.
haven't put it all together into a system that works together.
Yeah.
We have episodes of it out of necessity. Virtual healthcare is around because of the pandemic.
Uncoordinated would be the way I
Right.
would critique it.
Yeah.
Is that fair?
And incredibly inefficient.
Okay, so take these Rubik's cubes, take three-dimensional images, three of them. One is Cigna, one is Aetna, one is Oscar. How do you compare and contrast each to each other? Strengths and weaknesses.
Cigna was an organization that was in the infancy, some of its specialty businesses, et cetera, at the time. There was a lot more financial engineering going on than actual product engineering. Aetna was a company that around for 167 years. I think Cigna and Aetna are pretty close. And Aetna was a company that was sort of stuck in the way we always do things. I was always looking for the they department because I would talk to people and say, well, they told me we can't do that. Bring they up here. I'd really like to meet them.
The they department. It's awesome.
Yeah, they're so powerful. They're everywhere. And so at Aetna, it was about how do you get an organization to dance a different tune? How do you get ordinary
Teaching
people?
an elephant to dance.
Yep.
I think it was the former
ordinary
IBM
people to do
CEO.
extraordinary things. Yep. And so it was a fun project. And my last 3 years there was sort of joyful because everybody got it. And we were doing all sorts of cool things. And we thought we had more cool things to do with CBS. But when that happened, we found out we were back to financial engineering more than anything else. They needed our earnings flow. And then now at Oscar.
Before you get to Oscar, those 3 years that were fun at Aetna, walk me through that. What was happening? Give me
What
examples.
was happening is we created a trust model in the organization. So I'm sure there's a book, Dov Seidman, who wrote a book called How. And in that book, he talks about trust. Dov and I got to know one another. We started hanging out together. He started giving me some advice. He came in and talked to our team. And what we found is that trust is like love. You have to give it to get it. And when you do give it, people actually cherish that gift and want to give it back. And so we did it in our service organization as an experiment. My CFO, Sean Gerton, went, oh, this is going to cost us a fortune. But we said, what are the top 5 things you could solve on the phone by yourself without having to go somewhere? And we did a pilot. The team created a process to get information they didn't have, like phone a friend kind of processes. And then we let it loose with a budget, and they spent less than half their budget after 3 months. And we said the whole service organization could do it. And it was amazing. Retention, lower customer complaints. It was amazing to watch. And we started doing more of that across the organization where I didn't have to ask if something was done. I was told it was getting done when it needed to be done.
So this is sort of releasing the internal talent pool to communicate areas for improvement and then go after those areas for improvement. So,
right. And what you have
being a pipeline for problem solving within the business.
And what you have to do is you have to have a set of values that everybody can be guided by so they don't go off track. And we created those values, and those values were incredibly powerful and people could recite them. It was, deliver bad news early and personally, because let's get on it right away. We know when we're going to make mistakes. Let's get on them right away. We know what to do when we make mistakes and how to solve them. Attack people, not attack issues, not people. So let's attack the issues and work together as a team, creating better results. The third one was the toughest. Assume positive intent in everything everyone does. And when you don't see that, it's your personal responsibility to ask more questions, to find out what that other person's trying to teach you that you don't yet understand. And that was really hard, but that was an important one because the next one was, let's trust one another to be competent in what we do and take the power of the group together to move forward, which means you got to assume positive intent for the organization. And those values created a very strong result because we had sayings. The leading cause of failure is success. Success requires eternal vigilance, and things that Ron Williams brought to the organization when he came in. And so it was about the management process and how we worked together and what we focused on, and relying on the integrity and understanding of everybody sitting at the table that we were going to be able to perform better.
So you're disproving one assumption that grows over time that I think is constantly worthy of re-examination. The idea that scale at some point is its own worst enemy, and that you can't teach an elephant to dance. And yet there are many examples. It doesn't have to deteriorate. Companies that fall behind, like an IBM between the 70s and the 80s, can refine themselves in the 90s.
Mm-hmm.
We think of, the worst case examples, the Boeings of this world currently, but we don't necessarily give enough credit to the groups that come back, whether it's an Intel or a technology company like an Apple that lost its way and then refound its way.
Mm-hmm.
These things can come in waves. They do have to be led, right? They don't solve themselves, these cultural issues and these structural issues, these diseconomies of scale. But it is interesting that these businesses don't have to continue to deteriorate just because they've reached a certain scale. Fascinating to hear that. So I want to take another bugaboo and put it in front of you, a theory that we develop on the outside, but now we're talking to the inside, so we get to ask the question. When you're running Aetna and you look across the table and you see United, you see Cigna, you see Blue Cross Blue Shield, is this sort of a comfortable dynamic? Everyone's carved out their own territories, their own areas of specialization. Is this comfortable in the sense that that health systems are going to increase their pricing on you because they've got significant market share in a plethora of zip codes, because that's what they do? And God forbid you really push back on 5 to 10% annual increases for hospital care. And you don't really necessarily mind because it's the US, and the US is such a wealthy place, and employers, they'll find a way to afford it. And so will ultimately consumers. Is that the mindset? Or alternatively, we're missing something? It's highly competitive. You do push back on hospitals. There's lots of progress being made through competition from one minute to the next. Yes, there were challenges, but from the outside looking in, we don't really appreciate what it really means, the market dynamics of Aetna going up against United. Walk me through that mindset. What was that like?
So I would say it's the latter. It's a marketplace that generally runs on 5% margins with billions and billions of revenue. So your room for error is very small. For example, at Aetna, a 50 basis point change in trend was $980 million of underwriting margin. So small misses generate huge results. And it's not about the competition, interestingly enough. I never worried about my competition. I worried about us and what we knew about our markets and how we reacted to changes. So when we build an operating plan, we then make assumptions. Those assumptions are inherently wrong as soon as the thing goes on paper, because the world keeps moving. And when the world moves, you have to have an understanding of what are the risks and opportunities of that change against your business model. And so what we do is we create a plan that has a relatively equal set of risks and opportunities. And we have a management process that we follow those risks, those key risks. So when spreadsheets were the worst invention for business ever made because we think they're the truth, they're not. They're just models. And so what you need to know about a spreadsheet is not what are the numbers in the cells, but what are the assumptions around the 5 critical numbers on that sheet and how do they move? And if we can have a conversation of the relative risks of those and stratify them by priority, then we have to stand back and say, what do we believe as a management team? That we have the leadership to be able to handle this set of risks, because that's really what we do, is we manage risk.
I think that that's a very helpful answer because it reaffirms a view that I personally maintain, which has held me out as a bit of a contrarian over the years. I actually think US healthcare is mostly fixed and only partially broken, which makes me somewhat lonely in this world. And I actually think that you will struggle to find a company like Meta or Amazon generating $50, $100 billion of profit per year in US healthcare, maybe United on a good year. I haven't looked at their profit numbers yet, but their margins won't compete with groups like Meta and Amazon, ignoring AI capex and depreciation for that AI spend, which is recent. My point is, there is no real monumental accumulation of economic rent and monopolistic profit in US healthcare. Instead, you have pockets of success spread everywhere and scaling spread everywhere. You have 17 million people employed. And so the question we always need to be asking ourselves is the contrarian or the null argument for 17.5% of GDP spend, which is to say, maybe this is a good thing, you know, and which is really contrarian to say. But actually, when you break it down into different pieces, factoring for unusual obesity levels and minimalistic preventative care in the form of exercise, access to care in certain parts of the country, when you factor for GDP income through export of pharmaceuticals and innovation and R&D in drugs and devices, you end up with a sort of a 15% number of GDP. And what you see is other countries, OECD countries, actually closing that gap as the years roll by. They're no longer at 9% of GDP. They're at 11 to 13% of GDP. That whole group has moved up. And I'm not saying that, 15% of GDP is golden and it's a universal rule. I don't know what the answer is. And I think one thing's for sure, everything is subject to change. But again, to your point, the presumption is that it's all monopolistic out there. And I'm not sure that that's as accurate as it needs to be, that statement.
I think there are two big problems. One problem is that we have a set of economic models that collide into what's not really a system. And there's no rational reaction to those, rational bringing together those economic models. So, for example, physicians, clinicians largely work on a cash basis. That's their economic model. Institutions like, clinics and hospitals and surgery centers work on what I call a revenue basis. As long as we can grow the revenue, we can win. And that's why their price hikes are the way they are. And then you've got economic actors like insurance companies, biomedical companies, pharmaceutical companies that work on a margin basis. We need to get enough to generate a margin to reinvest in the business to grow, a pretty traditional capitalist model. When you collide those together, they don't work. You got 760,000 doctors or more. You've got 6,500 institutions or more. You got 1,300 insurance companies alone, let alone. And you put all those together and there's no rationalization of that. That's problem number one. Problem number two is the consumer is completely devoid of economic investment in the business.
And when I would have gone to that problem first.
Yep. And so I said this at the Republican Governors Association earlier last week. I said, let's take a test. If I have $5,000 to spend on a car and I only have to pay 10%, what kind of car am I going to buy? I'm going to buy a $50,000 car because the other $45,000 is free from my perspective. So there's no real economic actor in the system that's driving out high rents, looking for inefficiencies, exploiting economic differences to their own end.
You're saying the incentive, the way that we built it, is to spend more, not less, because the consumer is getting always this huge haircut on their personal spend. I totally agree with that. I think we're seeing that in ACA, right? We're seeing a lot of adoption, right? And we're seeing a lot of spend. So let's move the conversation to Oscar. Okay, so you look at Oscar and you look at ACA, and you joined 3 to 4 years ago?
April 3rd, 2023.
Okay, so you long enough to know how things are shaping up for Oscar.
Right.
It's certainly achieved scale. It's uniquely successful in the market. Others have not come close to replicating the Oscar model. So it is, if you were to say there's a winner in this space, it's clearly Oscar in the ACA market.
Mhm.
What's your vision as you join Oscar? Where do you want to take the business from
So,
2023 onwards?
Josh and I was at the time I was co-CEO of Bridgewater Associates, Ray Dalio's company, working with Ray on his transition. And I get a call from Josh and Mario saying, "Would you join our board?" Said, "No, I don't like boards. They're incredibly frustrating to me. I want to be an active operator." And so we met every so often and would talk about topics of interest about the company. And then one day, Mario looks at me and says, "Could you meet for an hour a week?" And so we started meeting for an hour a week. They would pick the topic, I would suggest some, and we would do deep dives. And so I learned a lot about the business model that they're operating. Up until that point, they had lost that $1.8 billion. They had never made a penny. So they consumed all their capital and they were struggling on cash. And so they said, "Would you run the company?" And as a result of spending time with them, I said, there are a lot of really cool things going on here. I think this would be fun because I didn't get it done with the CVS Aetna deal, which we brought to CVS, by the way. It wasn't the other way around. We thought we had a solution. It was just too big, too massive, too entrenched to change. And so I said, sure. And so they retired their founders' shares, gave the shares to me, and said, fix the company. And at the time we had started talking about that, it was $2.51 a share. So I spent the first 10 weeks and this goes back to our first question. I spent the first 10 weeks sitting with each team, doing a deep dive on every part of the business. How do we do this? Why do we do it this way? What would you do better? What do we do really well? And about week 10, Josh calls me and says, "I hear you're in meetings asking questions. When's something going to happen?" I said, "Don't worry. If I would have walked in here, Josh, I've screwed up everything this company has screwed up at least twice myself in my career, and I've had to fix them. And if I had walked in and said, you do this and you do this and you do this, they would have looked at me and said, who the hell are you? And why are you here?" So instead, I got to know the people because there are the people that I need to move to get these things done. I can't do it myself. I've tried that earlier in my career. It never works. And so we started moving on it. And, the first pillar of our strategy was run a really good insurance company because there was just so many things like fraud, waste, and abuse and, disputed claims and everything that were cash laying around. And what I thought was low hanging fruit was really watermelons rolling around on the floor. All we had to do is pick them up. And that put us on a trajectory to get the company in great shape. And we got to strategy far sooner than I thought we would because there was so much opportunity in just running the company right, doing the right things.
So let's talk about some of those changes. So headcount went down.
Headcount went down. Headcount went down
More recently.
a year later. Yeah.
More recently, yes. And you fill in my list is much weaker than yours. I'm much more interested in your list than mine. But I'll tell you one item that caught my eye is exiting California, 2024. That's a big decision. Walk me through that.
So the
I'm
company
sure
had
you
gone
got one or
out,
two phone calls on that decision.
well, at least. But what the company had gone out in its inception and did contracts with specific provider groups. Oscar was the first company to adopt the concept of narrow networks by market is a far better economic model than full on networks that employers buy because the economics are fundamentally different. And when I'm an individual buying, I don't have to take what my employer has. I get to look for my network in every market. With 75% of all the providers in a network, the narrow network model is the best economic model for the individual marketplace. So they started that. However, they had some relationships
But
that were just
managed care groups create narrow networks. What am I missing?
no. I mean, United, Aetna, Cigna all use their commercial networks.
Okay.
So when you think about a commercial network, they're built for employers with employees all over the place. And the benefit plan designs that they underwrite is actually their plan designs fit for the average of that employer. When you look at an individual market, you have to build a product for that individual consumer.
So individualized narrow networks.
Yep.
One layer
And then you
up
have to have narrow networks.
Okay.
You have narrow networks by market, and those are your opportunities so that an individual can find their network even if it's not yours. That's what you want.
Insurance. Yeah. Okay.
Yep. And what happens with that model then is because we socialize the risk in the ACA at the top level, we share the risk back and forth and equalize it. Catastrophic cases, you don't underwrite anybody more. You don't redline any because everybody shares in that burden at the end of the year. And the result is that you're really underwriting the network you built.
Yeah, you're underwriting the collective whole.
Yeah. You're underwriting the network. And so we had relationships from the inception of the company that just didn't work, but we couldn't get networks otherwise without doing those deals. So I sat down with the team and Medicare in 2 markets, one in Florida and then out in California, and said, show me what we need to do to this contract to make ourselves profitable in those markets. And they couldn't. There was just no way to get there.
It was
And
a
so we
cost of clinical labor, cost of care, frequency of care, patient demographic.
so the model I use is a model called
What was
PADU.
driving that extra idiosyncratic expense in those 2 markets?
It was just bad contracts. So I have a model called PADU, preferred, acceptable, discouraged, and unacceptable. And it's on terms and rates because terms matter as much. Can I collect overpayments retroactively? How do I contest claims that aren't properly prior authorized? All those terms were just bad terms. And what you're going to have to do is go back, and the cost was going to be too economically high in order for us to even stay in that marketplace.
What's the counterpart driving those bad terms? Is it health systems? Is it state regulators? It's not individual members. Is it employers? Who are you
No, it's
dealing?
health
Is it
system.
health
Health
systems?
system.
Yeah.
Definitely.
Okay.
I mean, we walk into a market and say, "Hey, we're here to help you in your marketplace. We're Oscar." And they're going, "We don't need another insurance company. Thank you very much.
Right. Right.
You have no market share."
I can see it in California. One of my favorite podcasts that I've done is with the former head of CMMI, Liz Fowler, and we literally go through state by state. It's just a table spreadsheet through the podcast. It's not our faces. And we look at state by state comparisons of healthcare spend, access to care, and you find the most everything you need to know about US healthcare, you can find in that podcast. And nobody does it. Nobody looks at per capita spend in Illinois versus California versus New York versus Florida versus Texas to
We
realize
do.
that they're wildly different. Nobody looks at, Medicaid coverage rates in Texas versus California to see that they're wildly different. Access to care, number of primary care physicians seen in the last 12 months in one state versus another. It's just so fascinating how wide the deviation is between one state and another state and another state. They're really practicing completely different forms of healthcare.
Well, New York City is a perfect example.
Yeah.
Try and find a primary care doctor in New York City.
Yep. Yeah. Thank God for the illusion of primary care, which is my former friend One Medical.
Yeah.
A little sprinkle of primary care for you.
I had a Medicaid doctor, and I loved him. He's a great doctor. And I'd show up in my suit, and they say, "Well, we don't take pharmaceutical salesmen here." I said, "No, I'm a patient." So, but
Speaking of
California,
access,
New
yeah.
York, New Jersey is a tough market. They're all tough markets.
Well, part of them are tough because they're not really incentivized to find a great payer like Oscar. They're very happy with their annual 10% inflation rates that they charge United and Cigna, and life is beautiful. My view of healthcare is there's maybe 15 foundational pieces to it, whether it's cost of drugs or whether it's health systems, nonprofits versus for-profits, or the aggregation of practices or the role of regulators. You find all these foundational pieces, R&D, what's going on in innovation. And if you're looking for what's not working, you need to cover all of them. And the best signal, the smoke that you look for to find the fire is inflation. And
Yep.
so it's not universal inflation at 10% because actually healthcare in the US has been growing at a rate of 2 to 3% for the last 15 years, not 10%. But
But if you
certain pieces within US healthcare have been growing at 10%. And there where we really need to look at market dynamics not working. And I think
well,
that's
if you look
fascinating.
at Roy, if you look at the ACA for the last 4 years prior to this year, the trend rate was 3.5% for 4 years in a row.
And that's healthy. That's healthy. But
It was less than inflation,
but
which
then
was the definition of health
how do you
reform.
explain 10 to 15 billion dollars of subsidies in 2010 and 120 billion dollars of ACA subsidies in 2024, 2025?
The market grew to 24 million people.
So on a per capita basis, you're saying you won't see more than 3%.
At per capita,
So that's
3.5%.
just sticker shock journalistic bias. That's not actual economics, is what you're saying. That's pretty
No, it's
cool.
never economics. The notion that $1.5 trillion is being spent on illegal aliens is insulting.
Well, the other evidence you offer that really reinforces that, and it's very. I just interviewed the Wall Street Journal journalist. That podcast is coming out in the next few days. That wrote the article that took the other side of this. That
Yep.
article just came out in the last week and argues that I think the headline was "How to Fix ACA," and it went headfirst into tax incentives and subsidies and how they were skewed towards payers inflating prices because the government would underwrite. And the argument was, and I fell for this, look at this $15 billion spend that just became 130. And neither of us were like, oh, well, on a per capita basis, what is it? Which is sounds like 3%. But the other argument you offer, which is I think fait accompli, is Roy, we're the number one provider in the space, and we just broke even last year.
Yeah, so we're not rolling in dough, that's for sure. But let me give you some comparisons.
You were turning Oscar around in 2023.
Right.
Well, that's quite telling.
In Medicare, it's $14,754 a year medical cost. In employer-sponsored insurance, it's $9,437.
Depending on which state, but yes, keep going.
Yeah, that's the average nationally.
Right.
In Medicaid, it's
Yeah.
8,200.
Yeah.
And the ACA is 7,300.
Oh my word, that fact needs to get out. That fact needs to get out there. That's a big deal. And so what you're really saying is,
that doesn't include the subsidies.
What you're saying is we have just shat the bed because we had 20 to 30 million extra insured here that previously weren't, which is exactly what all of us have been pushing for, how to get 50 million down to 20 million uninsured. And on top of that, we were getting the best economics for it.
And uninsured went from 15 to 8%.
Yes.
Which reduced uncompensated care at hospitals by $10 billion a year.
Yeah, yeah.
$10 billion a year. Hospital costs, uncompensated hospital costs.
Yeah.
And so is it a surprise that the AHA is with the insurance company saying we need to keep ACA?
Yeah. Yeah. Okay. We have some work to do here. I got to rally to your cause.
And so here's the part that I think changes the game. Every time you put consumers in charge of how they spend their money in any market, things get cheaper. Books, cars, travel. When you look at that economic change, it's because the person who is using the money actually has to decide how to use it.
Walk me through that. How does I'm not part of ACA on an individual level, so I haven't experienced it with my own eyes. How does a consumer get more empowerment in decision making through an ACA marketplace policy versus traditional?
Because they pick their own plan.
Yeah, but we pick plans all the time.
You get 3 from your employer and you get to pick one of 3.
Yeah.
They get to pick their own plan from many.
Yes.
Across every market, number one. Number two, and this is the biggest insult, I think, for ACA insurers, is they say, well, there are people in ACA who never use their health insurance. There are people in every health insurance company that never use their health insurance in a given year.
For sure. I don't have an issue with that.
But here's the point. So we had a bunch of
responsibility. So if in hospital land, patients typically pick up 2 to 5%, and in outpatient land, patients are picking up now 15 to 25%. How is that different in ACA on a per dollar basis, cents per dollar? What's the patient?
I mean, how much do they pay, or
patient responsibility? What is it in ACA versus
patient responsibility? Last year, 2 out of 5 Americans borrowed $74.9 billion from banks to pay their out-of-pocket costs in healthcare.
Yeah, no, but different question. That percentage that patients represent of the dollar spend versus the insurance picking up, right? The underwriting. What is it?
Okay, so here's you have to step back and look at people buy a 0 premium plan, a lot of them. And a lot of them do it so they don't lose the house if they get sick.
Right.
If they get really sick. So they're not buying it to use the insurance, they're buying it to create coverage.
Prices.
Safety net, right? So, and those people should be able to do that. And so it has high deductibles and copays, but they're not paying them because they don't use them.
No, you're being asked a question by someone who's not sure that high deductibles and copays is a bad thing. If we're talking about patient transparency, responsibility, decision-making, accountability, you can't get one without the other.
That's right.
It's all free. You're in charge.
Right.
I'm not sure I believe that.
So I go shopping and I look at my plans and I trade off how much do I want to pay in premium and how much do I want to pay out of pocket if I get sick.
Okay. So patient responsibility much higher, which should drive far more engagement.
We have a product for diabetics. It is one of our best producing benefit plans because we actually engage them in their care with our technology, get them involved, and they join it because we say, hey, if you want to get your diabetes fixed,
So premium super low, actual sharing and actual cost pretty high, but boy, does it get people focused, is what you're saying.
Right.
I think that works on an
And we
economic
just
behavioral
launched the
basis.
product. So if you take traditional insurance, break fix, you get broken, go to your dealership, get fixed. If you look at disease management companies, which is we now have diabetes, we have asthma, we have COPD, and we have comorbidity plans. We encourage people to come because they want to get better. And we give them options on how to do that. Our latest development, which I did with great trepidation, by the way, was we launched a product called Hello Meadow. It's a lifestyle product for women going through peri and postmenopause. And we provide bone density scans, hormone replacement therapy, all cognitive behavioral therapy and counseling, where they can go through this stage in life, not having to hide in their house or standing in front of the refrigerator because they got hot flashes. They can actually get services. Now, here's the second thing that happened. In our diabetic product, we saw an influx of African American Black women who were pregnant coming in. We said, what's going on there? You know what it is? High gestational diabetes in the Black community. So they said, I want that product that covers diabetes because I'm having a family and I'm going to be pregnant and I need that product in case I have gestational diabetes. I want my child to be healthy. Those are real choices that you don't get with your employer sponsored plan.
So you're much more consumer orientated, customized plans that engage patients as partners. I can see the interest. So let's for a second ignore the large question, the elephant question in the room regarding ACA and subsidies and incentives. Let's assume all of that gets resolved and you're back to running this business and executing vision. Where do you
Yep.
take this business over the next 5 years, given the other headwinds, tailwinds that are going on, particularly AI, which I think is totally transformation of all things healthcare? And what I see really transforming is payers' ability to engage their members and
Yes.
understand their members and preempt their needs and wants. For better is for better, and for worse, payers have to be careful. Obviously, we see the United example of denied claims. So that risk exists. What I see is actually other actors doing the same thing. So health systems are also studying their patients using AI and their own ownership of data. All clinicians are interested in that. EMRs are also highly interested, and so is the tech universe. So you've got a wave of California-based early start or California-funded early startups, the VC community, that
Yep.
are flooding into the healthcare marketplace with, I've got it. I've solved for patient experience. Follow me. So there's more noise than ever in this question of consumerism of healthcare. How does Oscar fit into all of that
Yep.
over the
So
next
I
5
think
years?
I think AI companies, all these flourishing of AI companies, is indeed a bubble, and I'll tell you why. They have their own platform that they want to sell you to put your AI on, and then pay rents forever for using it. And we don't do that. We have the first new platform in healthcare since 1972, front to back. It's digital native, cloud based, and we have one set of data, one version of the truth, all the necessary things to do AI on our own. So we have over 30 large language models that we've implemented over the last 2.5 years on the back end of the business that have reduced our operating costs. We have also launched 2 agentic AI models on the front where patients and physicians can collaborate on their next step in care, understand what's required to get that care going, do it automatically through the system, and get out of pocket costs for the patient based on what they've designed using their medical record in ChatGPT. So we're using these tools at scale. We're the only insurance company that are as far ahead as we are. So the AI thing, and also what we did is we got rid of 100 engineers last year, software engineers, because we have AI doing that too. It's doing the basic coding. So we're using it, but we're using it first on the back end and very carefully on the clinical side because we don't want to hurt. We had a bot we were working with, and it's still in the lab. We watched people using it, and it's like 300 patients or 300 members that we use, and we were watching it, and we saw in a couple of cases suicide ideation that only a human would recognize because we know it, empathetically when we're talking to somebody that the machine missed. So, and we got those people help. So we have to be careful about how we use AI. I don't see AI doctors around the corner, the boogeyman that it's all going to change. It's not going to change that quickly. we have to be careful. We can help doctors, but we still need the cognitive capabilities of physicians knowing their patients well to be able to do a lot of the work, the laying out of hands versus the machine work, the tests. But so here's my case. I believe every American should have an opportunity to buy individual healthcare coverage. And I believe that employer-sponsored insurance designed 80 years ago no longer works. I believe value-based contracts are a joke. None of them really work. None of them really change physician behavior. So what we need is a model where we identify by market, and we're doing this work now, where we see clusters of clinicians and institutions that work together that practice better medicine. They're the people that always win in value-based contracts. It's not because of the contract, it's because they practice better medicine. And I would pay them fee for service plus if I could find those in every market.
Bottom up
I
as
know.
opposed to top down.
Pardon?
Bottom up as opposed to top down. Find examples of excellence and differentiated outcome and invest in those, and don't superimpose hard written contracts in order to achieve those outcomes. Those outcomes are there before the contracts ever showed up.
Exactly. And Oscar has an NPS of 68 in an industry that averages 0. And so if you look at us marrying up with people that have great NPSs from a patient standpoint, it's a marriage made in heaven. And then what we want to do,
NPS, is that satisfaction?
Net Promoter Score.
NPS. I thought you were saying okay, NPS.
Yeah.
Yeah.
So what we want to do is we want to say every American has an account, and that account is a place where you can put employer money, government subsidies if you need to, and your own money, and you divorce the investment from the financing decision. One of our problems in the economics of healthcare is we conflate investment and finance. Being a Detroit boy, if I went to a dealership and said I have $350 a month to buy a car, what kind of car can I have? You're going to get cheated. But if I go in and say I want this with these sorts of attributes, how much does it cost? And I'll tell you how I'm going to pay for it later. And that's what we should do in healthcare. So these accounts should be tax advantage, think Roth IRA, HSA kind of thing, where I can then decide with my money, find my network and my market, find my plan design that works for me this year. So if I'm going to start a family, I want a great obstetrics program. If I need a knee replacement, I want a great access to great orthopedics. And by doing that, I buy my network and my plan, and it's mine forever because I've divorced the financing. If my circumstances change, the money comes from different sources into my bucket.
I think the fear. Okay, so you're substituting the tax benefits of employee insurance with tax benefits of a tax structured savings plan, healthcare savings. Okay. So, because otherwise that would be an impediment, right? No one wants to go from.
Right. That's the reg you need at the state level and the federal level.
The 40 cents kicker in the form of tax savings. Okay. All right. Mark, we've covered a lot. I can't believe I didn't ask you a single question about Ray Dalio, but that sounds like an altogether completely different podcast. That's another rabbit hole.
Ray's a brilliant man. I love being with him.
I've seen him speak in person and obviously read a lot of his books.
Yeah.
His own version of Fourth Turnings. Definitely see it, believe it. What a great historian and a gift to the rest of us. And so are you, Mark. So really couldn't be more grateful for your time this morning. I hope you enjoyed it.
I did, Roy. It's great to be with you. Thanks.
More to come. Thanks, Mark.
Thank you for joining us on Analyzing Healthcare. Stay informed and stay inspired. Don't forget to subscribe and visit scale-community.com to become a Scale Community member. Until next time, keep exploring the ideas that shape our healthcare systems.